chest tube next generation question in order to consolidate the lecture that I did earlier on, in order to you can see how they can frame the question. This is the question that I made up, but it's basically based on the note and things I think they will ask you, and based on my experience, what I see, how patient comes in with chest tube related problem. So what is the scenario? A client in emergency room that tell you it's an emergency. The way to go about doing these cases is to pay attention, open your eyes, relax. The question, they will be long, but just breathe, take a deep breath, said, I got this. Give it to me. I'll take it. And read through the lines. And when you see buzzwords, you highlight it. So I would do that. And look at what I'm going to do. A client is in emergency room. It tells me that this is an emergency case. So I got to be sharp and take care of this patient. A 40-year-old construction worker fell. So this is the trauma from the rooftop and landed on the side. Okay. He was brought to the emergency room. Client report what? Left arm, chest, and leg pain because he landed over there. He has shortness of breath. That's a buzzword. Okay. Chest pain was worse with inspiration and expiration, another buzzword. So we see shortness of breath and a chest pain that is worse with inspiration and expiration. And it describing the pain 8 out of 10. That's one of your vitals. So his pain is 8 out of 10. That's really bad pain. So we have a couple of buzzwords. What is his vitals? His temperature is normal. His heart rate is high. Buzzwords. The blood pressure look normal. Respiratory rate is going up a little bit. SAT 90% on 2 liters. Another buzzword. Is anxious. Nobody get anxious. You can be nervous, but whenever you are you are anxious, that is air anger. You're looking for oxygen. So we call it air anger, basically. So this is another buzzword. So I know somebody fell from the rooftop. He landed on the left chest, left arm, and the leg. He has shortness of breath. He has inspiration, expiration, and pain with chest pain. And he's anxious. He's tachycardic. His heart is in the 90s. His heart look fine. S1, S2 present, no mum. He has decreased breath sound on the left. So this is the lung. Okay, and this is your left side, and this is the right side. There's decreased breath sound here. And there's paradoxical chest rise. That means when you take a deep breath, when we normally take a deep breath, our chest rises. Then when we breathe out, our chest falls. It's because of the diaphragm. Diaphragm expands and then relax. When we say paradoxical, when you take a deep breath, the side of the left chest that is supposed to rise, it rather go down when we take a deep breath. And when we really blow out, that chest rises up. So it's paradoxical. So this left chest, it doesn't go up with inspiration. It goes down with the inspiration and go up with expiration. So that is the paradoxical chest movement. His abdomen is soft, non-tender. He has bruising on the left flank. He also has bruising on the left side, and his pulses is fine. What do you think? I fell, landed on my left side of my body. I have chest pain. I have leg pain. I have desaturation, okay, on 2 liters. This is desaturation. 2 liters, you should be higher than that. I have tachycardia. I'm anxious. My chest is not doing what it's supposed to do, and I have decreased breath sound. Something is not right. You should think, you should know what is going on. A decreased breath sound and a paradoxical chest rise look like this patient has rib fractures. That's why that chest is not rising. And that rib probably has punctured the lung. Okay, this is the lung. It has punctured the lung on the left side. So the patient has developed pneumothorax. That's why they have decreased breath sound here. They have decreased breath sound, paradoxical chest rise. They desaturating. They have pain with inspiration, expiration. That's classic for pneumothorax. Inspiration and expiration. That's that problem. So What did they say? Which of the highlighted information need further intervention? Relax. All it's telling you is which one is a priority that you should be worried about. They are paying 8 out of 10. You should worry about it. It's too high. That's your vital sign. That means something's bad is happening. A is tachycardic. We should worry. It's all due to anxiety. Okay, a SAT is 90 on 2 liters. You should worry about it. It's very anxious. That's air anger. We should worry about it. It has paradoxical chest rise. We should worry about it. This shows multiple rib fractures on that side. It's bruising on the leg. Okay, so that's not a problem. So we don't need to worry about this. His pulses is splash too on both sides. We don't need to worry about. So those that we need to worry about is A to E. That's how you do this portion of the question. This is a select or apply. It's plus minus. That means if you make a mistake, we take a point. Please pick those you're confident. If I'm confident on these 3, 4, I'm picking it and I'm getting 4 because there's 5 answers here, right? So I get 4 out of 5. I don't want to pick everything and lose all the point. If you think you 3, you're confident, just pick and you get 3 out of 5. It's better than 0. Select or apply. Now, you're not going to get 0. So don't panic. Just relax. Pick those you're confident. And you see that you keep on going through this process. The computer has to shut down at 85. After a quick assessment by the physician, the nurse received the following orders. We need a chest x-ray. We need to give the patient morphine. And we need to put the patient on a non-rib breather because his SAT is going down. As the nurse prepared the patient for the chest x-ray, patient becomes anxious, buzzwords. I said, pay attention to buzzwords and relax and look at them. Confused, buzzwords. Excited is 80, buzzwords. On the non-rib breather, is going down. Blood pressure, look at it. Systolic is 90, diastolic is 80. That is what we call narrow pulse pressure. The diastolic is getting closer to the systolic. This is a narrow pulse pressure. It's bad. That means your heart is not pumping. The patient has muffled heart sound. That is also bad. Buzzword. It can't pump anymore. Then we have tracheal deviation. The lung is pushing away from the problem of the injury. And then you have jugular vein distension because the heart is being squeezing. You're getting the left heart failure going to right heart failure, and then you have JVD. So all is classic. And if I draw it for you, this is your lungs, okay, and your airway is here, and your heart is here. You have pneumothorax here. Air goes here like that. So if the air comes in like that, all you do is you push on this, you keep on pushing on this, and what will happen? This trachea will deviate towards this side. It will move this side. So you have the trachea going this side. The heart also get pushed here. And so when it get pushed here, everything here is squeezed. The superior vena cava and the inferior vena cava get squeezed. And that's how you get JVD. Okay, so what do you think is going on with this patient? He's not getting cardiac tamponade. Cardiac tamponade will not do that. Even though it will give you JVD and a muffled heart sound and a narrow pulse pressure, there's no tracheal deviation. You're seeing these signs consistent with cardiac tamponade is because the heart is being squeezed. The breath sound changes everything, and the saturation, the desaturation. This is not simple pneumothorax. Simple pneumothorax doesn't do that. It doesn't cause muffled heart sound, tracheal deviation, JVD. It can cause anxiety and such of this, but it doesn't do that. This is tension. The pneumothorax has now developed into a tension. It has pushed the heart so far and trachea has deviated. It's now compressing everything. And that is tension pneumothorax. And so this is the right answer. We don't have myocardial infarction. There's nothing, even though they have chest pain, it's not myocardial infection. So there's difference between just a pneumothorax. Pneumothorax, you will have decreased breath sound here. That's all. But when they develop tension, the pneumothorax has grown to the point they start pushing things away. That's what we call tension. It causes tracheal deviation. It causes cardiac tamponade-like symptoms. And then it's an emergency. We have to do something right away. So what do you do? The nurse should anticipate which of the following priority order. What do you think? Priority order, plus or minus. So you pick one answer. This one, you got to pick one answer. And whether you get it wrong or not. So we know the patient has tension pneumothorax, right? It's not just a simple pneumothorax. It's not cardiac tamponade. Okay, and it's not MI. So which one is this? Morphine, oxygen, nitro, aspirin, that's MI. What is pericardial centesis? That's the management of cardiac tamponade. Intubation, if you intubate this patient, even though he's saturating, he will die. You have tension pneumothorax. You don't have time. Tube thoracostomy. I intentionally use this word because I don't know whether they will trick you guys. Usually it's a chest tube placement, okay? That's what they write. But when you have a body like that, the tube go into the chest, the hole is ostomy. So called thoracostomy. There's a tube going through a hole into your chest. That's the same thing as chest tube placement. So tube thoracostomy, I do this all the time, so I know what it is. That's what I do. So chest tube, we call it, the proper name is tube thoracostomy, the tube going through the chest, through a hole, and the hole is called ostomy. A needle thoracostomy, a needle going through the chest through a hole. So what is your management for tension pneumothorax? I intentionally put this there. Tube thoracostomy is wrong. You don't have enough time to put the chest tube. This patient has a tension pneumothorax. You need to decompress the heart, the lungs right away in the chest. So you put at least 14 gauge, either 14 to 16 gauge needle in the second intercostal space, in the anterior mid axillary line, and you put it there, and then you decompress. You hear a hissing sound that will come out. So once again, you need a 14 to 16 gauge needle. Put it in the second intercostal space, in the mid anterior axillary line, or whatever you want. You can put it in fourth axillary line or mid clavicular line, but anterior, and that will decompress the chest, and then the patient will do well. Then after that, you put the chest tube in. So the chest tube is tube thoracostomy, the needle decompression. So another word, if you see needle decompression, immediate needle decompression, yeah, that is this one. So this is the right answer, needle thoracostomy. Now, a needle thoracostomy was performed. Which of the following is consistent with the diagnosis? In your test, they will give you the answers as you move forward. Don't panic. Oh, I get it wrong. So you start panicking. Relax. Take a deep breath and say, I got it. They give me answer. Like you give it, you made a mistake and somebody give you extra credit. That's what the way I see it. You made a mistake. They tell you, oh, this is the answer. Use the answer to answer the next question, and you keep on moving. So now, forget about if you get it wrong. You have 1, 2, 3, 4, 5, 6, 7 plus different layers that you can get 20 points here. Why do you have to worry about what? I've given you the answer. Tube thoracostomy was performed. Which of the following is consistent with the diagnosis? Now I want to distinguish between the three. The tension pneumothorax is the pneumothorax that is now causing tamponade-like symptoms. A simple pneumothorax is just a pneumothorax. There's decreased breath sound over there. Cardiac tamponade, you know, there's a muffled heart sound, there's a JVD, there's a narrow pulse pressure, hypotension. So What is the difference? Tension pneumothorax causes hypotension. Will cause hypotension here. So we will have hypotension. Simple pneumothorax doesn't do that because it doesn't cause tamponade, like I call it cardiac tamponade like symptoms. So it doesn't do that. Tamponade will cause hypotension. You have JVD, yeah. Tension pneumothorax will do that. Simple will not do that. Cardiac tamponade will do that. They both have muffled heart sound. This one doesn't. Simple pneumothorax doesn't do that. Cardiac tamponade does that. Absent breath sound opposite the injury. Watch this one carefully. If this is your lung, this is the left side, this is the right, okay, and this is the trachea. Remember, in tension pneumothorax, this lung is being squeezed. It's completely squeezed because this lung is moving closer to that. If you listen here, there will be a lot of air. That is what we call hyper resonance. This one, hyper resonance. You see, there's air will be bubbling. If you listen to the right side, you will not hear anything because the chest is being, the lung is being squeezed. Okay, so that will cause absent breath sound opposite to the injury. There's no breath sound here. If it's just the simple pneumothorax, it doesn't do that. The simple pneumothorax, this lung is still can open. This is the only lung that is expanded. And when you listen, you can hear breath sound. If you listen here, there's decreased breath sound and there's hyper resonance here. And because of the bubble of air over there. So that is the difference between them. So, oh, I clean everything. So this one here, 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 this one here, here, here. So absent breath sound opposite the injury is only tension pneumothorax. In simple pneumothorax, you can still hear sound on the uninjured side. Tracheal deviation, you see, is in tension pneumothorax. Hyperresonance on the affected side. So for the affected side, yeah, tension pneumothorax, you can hear it, and the simple pneumothorax, you can hear. Chest pain, all of them will cause chest pain. And that is the way you can get this done quickly. Once again, it's plus manual scoring. If you don't know, don't worry. Just pick those you think you're confident. Don't select everything. Just pick those, otherwise we take a point. Plus minus, pick those you're confident. Okay, if he tell you 0, 1 scoring, yeah, this is good. This is your friend. If you see the answer choice and it says 0, 1 scoring, that means they're not going to take a point from you. So you can select whatever you want. They're not going to take a point even if you get a mistake. But if you see plus 1 minus 1, yeah. But most of these tables are plus minus 1. So don't pick just things you don't know. Now, 5. What is the issue? This is important. A tube thoracostomy was finally placed. So we placed a needle thoracostomy. Now we place a tube thoracostomy. That means we place a chest tube. Okay, now we have a chest tube in place. Which of the following the nurse should anticipate in the plan of care? I put select all that apply. Whenever you see select all that apply, that means it's what? Plus negative. If we make a mistake, we take 1 point. If you don't know it, don't pick it. If you're confident, you pick it. What is the problem? So which one is good? 250 ml of sterile saline at bedside. Everybody who has chest tube should have this on the bedside, right? Because if the chest tube come out from the pleural vac, you put the chest tube in this saline after you wipe it, and then you go and get a new pleural vac, like I did in the lecture. So this one is good. Antiseptic wipe at bedside. So like I said, the same thing. This is the chest tube, and then the tube coming out from the patient. If it come out from here, you wipe it out, you put it in a 250 cc of water, and you go and get this again, another pleural vac. So we need this at bedside. These first two, you must have it at bedside. You must every time. You must every time. I'm repeating it. Suction set at 20 centimeter per mercury. Yeah, the suction is set here. And there's a gauge here. You put water here and it will be at 20 centimeter per mercury. So that's what you do. Pleurovac drainage at heart level. That means if this is the patient, it's at heart level. No, it should be below the heart level. So this is wrong. Chest X-ray. Yeah, after you put a chest tube, we need a chest X-ray. Document chest tube output every hour. This is a trap. You don't need to document it every hour. Sometimes Q6 or per shift. So you don't need to document every hour for pneumothorax that was placed. If it's for hemothorax, yeah, hemothorax sometimes Q4, depending. But this is pneumothorax. It should be placed at per shift or Q6 hour, sometimes 4 to 6, a minimum Q4. How about that? A minimum of Q4 and a maximum per shift. A daily dressing change on the chest tube insection site. That is a trap. Okay, if this is the patient and the chest tube is coming from the patient here, this dressing, you don't change it until he has to. Most of the time, it remains sterile. We don't change it until we're about to pull the chest tube out. Don't go and disturb it. Every time you go and disturb that dressing, you're exposing the patient to air to enter into the chest. So there is no need for daily dressing change. Just leave it alone. So this is also wrong. This is wrong, and this is wrong. In 17 spirometer, yeah, they get to expand their lung. So this is good. Bed rest, no, they need to get out of bed and walking. So they need incentive spirometer. They need to get out of bed walking. You don't need to change the dressing, okay? You don't need to document chest output every hour. We need a chest X-ray. The Pleurovac should be below heart level. We need a suction at 20. We need antiseptic wipe, and we need a 250 cc of sterile saline at bedside. After shift change, the nurse noted, the night nurse, a new nurse came in, noted several findings with the chest tube management. Which of the following need immediate intervention? She noted a bunch of stuff, so she was worried. Which one I need to intervene? Select or apply. Pick those you're confident. This is a +1, -1. So which one I'm confident? Movement of fluid column in the chest tube with inspiration and expiration. What am I saying? If this is the Pleurovac and this is the patient, the chest tube go to the patient, and there's a fluid column collecting in the patient. So you go up and down, up and down, up and down. Whenever the patient take a breath, it moves. Whenever the breath comes, that expirate, so it moves. So it moves with inspiration and expiration. Is there anything wrong with it? Do you need to intervene? I don't think so. That's an expected finding. Movement of fluid in the chest tube with inspiration and expiration. This is what we call tidalin. There is tidalin in the tube. You should also see tidalin in the air seal or water seal chamber. You see it in the water seal. That is expected. I don't need to intervene. 200 ml of serosanguinous output in the collection chamber in 6 hours. So only 200 came out. And like I said, if it's greater than 3 ml per kilo per hour, and they don't give you the weight of the patient, but 200 in 6 hours, that's reasonable. It's not bad. So this is not a problem. Intermittent tidalin in the water seal chamber, like I told you. There is intermittent tidalin. There's back and forth tidalin. That's the patient, and it go into Inspiration, expiration, inspiration, expiration. There is tidling. Water go up and down in the water cell chamber. You should expect tidling in the water cell chamber. I intentionally put it intermittent, but that's it. Inspiration, then you wait. Aspiration, inspiration, expiration, inspiration is tidling. You see it in the water cell chamber. So this is good. I don't need to intervene. 1 to 2 air leak in the air leak chamber. Guess what? The patient has tension pneumothorax. So we have pneumothorax. Whenever you put a chest tube in, you're supposed to see air leak for pneumothorax. That is expected. After 2, 3, 4, 5 days, 2 days later, after a minimum 2 days, the air leak should resolve. If it doesn't resolve, it tells you there's a lung injury. So it is expected to see air leak in the air leak chamber. If you continue and it's like air leak of 4, 5, 6, yeah, I'm worried. Air leak of 1 to 2 is normal. It's just a beginning. It's been 6 hours since I put the chest tube in, so it is going to resolve. So I don't need to. A 3-sided tape dressing at the insertion site. So if this is the patient and the chest tube is going here, this side, the dressing should be four-sided. 3-sided means air is entering into the patient's lung. Thus, we have a problem. Continuous bubbling in the suction chamber. The suction chamber is here. You should expect continuous bubbling because this is the suction coming in. It's bringing suction into the system. You should expect continuous bubbling. That is good. I don't need to intervene. No bubbling in the collection chamber. The collection chamber is here. This is the collection chamber. This is the water cell chamber. And this is the suction chamber. This collection chamber, there shouldn't be any bubbling. All it does is drain stuff. It drains stuff from the patient. So there's fluid there. It should not bother you. Continuous bubbling and no bubbling in the collection chamber. That is an expected finding. That is what I want to see. I'm not intervening. Chest tube drainage system hanging on the side rail. This is a trap I put there. It came to me and I put it down. If this is the patient bed, I'm not good at it. And this is the side rail. The side rail is usually movable. The bed itself is fixed. It doesn't move. You don't want to put a chest tube in the movable portion of the patient. Otherwise, it go up and down, up and down. It's likely to get dislodged. You put it on the fixed portion of the bed, either the lower or the one in the middle here. The fixed, non-movable aspect where you usually place the Foley. So no movable aspect of the bed so that it doesn't go up and down. This one, we have to intervene. So we intervene here, and then we intervene here. And what else? I think that's all. This movement is good. This is good. Intermittent tidling in the water, air leak, 1, 2, continuous bubbling in the suction chamber, no bubbling in the collection. So only 2, sir. And this is the end of it. I intentionally put this question together, same as the lecture, to supplement it. I don't want anybody to make a mistake on chest tube. There's no way. So this is for you. Take care of yourself, keep charging, and then subscribe to the channel if you have not. If you have a friend who is struggling, show them this video, and I hope they like it and they'll be able to answer questions on any chest tube. Good luck and all the best of luck. Never stop charging. Bye-bye.